All right. Well, we're here with our surgical robotics experts, Steve Bell and Joe Mullings. Guys, I've suffered from FOMO for most of July. Now I'm suffering from ROMO, regret of missing out of SRS 2025. I thought I'd be okay, but then I watched your posts on LinkedIn, and Steve read your blog post, and I can't live with myself without knowing what happened in Strasbourg. So. We're going to unpack many of the things that happened and many of the things that I'm curious about. I hope you guys bring up some observations of your own. But first of all, guys, welcome and thanks for taking some time to unpack the week.
Good to be here, Tom. As always, Steve, good to see you, my man.
Great to be here with you guys. And I don't know, Joe, is it what goes on in Strasbourg stays in Strasbourg or?
Yeah, certain things. If you're a foodie, it's not a great town. If you're robotic-y, it was a great town for that week.
Yeah.
We'll try to get into those areas later. I've got a list here, but I guess the number one thing I want to hit upon first is telesurgery has been all pretty much we've been talking about for I've been talking about for the last month or so, and it certainly led into SRS. Strasbourg, of course, being one of the two sites linked to the Lindbergh operation in 2001. I don't know if that was coincidental or not. Maybe that's just where all the companies are located. But I thought that was kind of a neat coincidence. Let's unpack telesurgery as a platform. Steve, let's lead off with you. Have we moved on from novelty gimmick to it's a thing?
Oh, it's a thing.
Yeah.
It's still early innings, still very early innings, but it's a thing. I think my mind's shifting away from it's just, the act of telesurgery. I think for me now, it's the act of everything. So it's the telepresence, the teleproctoring, the telepreceptoring, telesurgery. I think that what we're starting to see is it's becoming a platform rather than just a thing. That would be my 30,000 foot takeaway.
And Joe, how about you? I had a chance to experience Da Vinci's telesurgery capabilities in a visit to Atlanta. It was pretty amazing. What was your takeaway from last week regarding
Yeah, so,
telesurgery?
so I take a slightly different approach on the telehealth side of things, and let's just call it telehealth. I agree with Steve. I think the teleproctoring, um, teletraining, but where I have a challenge with the telepresence is if it's going to include the omission of the surgeon or the interventionalist from the room. Because while we've solved the technical issue, it's the human issue and the psychological issue and the leadership issue. Because if you go into any OR, and that culture's been built on an idolized leadership, one voice, one commander in the room. And when you have that commander in a room and he or she has the ability to read the room, to see what's happening, what's not happening, to watch the eyes, to watch their care team work, they can usually head things off at the pass. But when you pull that leadership entity out, the physical being out of the room, and you try and dial it in, and there's a life at risk on a table, I don't think that we've really addressed that yet appropriately. And I had some very private conversations with people, and I brought it up in the endovascular side. And number two is where medtech screws up a lot with their technology is they drop it on the doorstep of the hospital or the
Mm-hmm.
OR, and they don't have a change management process in place. And when you talk about making that massive of a change in an OR and you don't do the work already for the site of care, adoption will end up getting a hit.
So Steve, and thank you by the way for the baseball reference earlier, reaching across the Atlantic and giving me what I need, a good early innings metaphor, so I can understand. There are a lot of surgeons at SRS last week. How do they view all of this? Are they excited about the opportunities? Are they like, yeah, this is fine, but this is not necessarily a priority for me? What's the read you get from the clinical folks you talk to?
I saw it as across the spectrum. I see some people that think it's just nonsense and it's just a flash in the pan. It's a
Hmm.
tech demonstration. I think there's other people who are seeing it more than what it probably is. And I agree with Joe on this that is this going to be resolved very quickly for an everyday surgical or intervention? I think we're a long way from that.
Sure.
is there kind of a middle ground? And this is where a lot of people said, could be some interesting use cases. So you go and do an initial live proctoring, but you don't then fly there for the next 4 weeks, which we don't have time, we don't have money, we don't have surgeons who are able to do that anymore. And do I telepresence in to do initial caseload support for 4 or 5 cases? I think people can get their heads around that. So there's everything. I think it was the spectrum from enthusiasm to skepticism I saw.
Yeah, no, and Joe, I think your point's right on about the change of the dynamic in the ER, but I can't imagine telesurgery will ever be the primary way that surgery is performed. I mean, it's always going to be a subset of in-person surgery, right? I mean,
Yeah,
we're
I
not
think it
looking.
also depends on the complexity, Tom,
Yeah,
of it, right? So you
true,
got that,
true.
and people refer back to that hub and spoke, especially in the neuro model and stroke, right? And on paper, it makes sense. It makes sense that, you know, if you're out in Wyoming somewhere and you have a stroke, and I think Adnan Siddiqui and Ryan Matter in the endovascular session we had talked about the stats of the mortality rate in those areas versus major cities substantially
Hmm.
higher. But when they said it's the best solution we've got, and what do we do? Just let the patient die or have a compromised life? Try and explain that in the court of law when you've got a care team that does maybe one procedure a week out in Wyoming, and they've got the ability to have that telestroke solution. Patient gets on the table. It's a new technology, and the litigious nature and the bottom feeders that ruin healthcare for us on the legal side will, when there's a less than optimal outcome, the surgeon will say, well, listen, it was better than just letting them die.
Right.
That in itself is a puzzle that's going to have to be navigated, and that's a big fear of mine. Is all you need is one of those cases, and hospitals are just not going to do that, regardless, even though rationally on paper
Yeah.
it makes sense.
No, that's very, very real concern. Steve, final question on this because I want to cover a lot of other things. Is there an opportunity, more of an opportunity for autonomous surgical systems that kind of have a built-in, or systems, surgical robotic systems that have a built-in sort of guidance system that elevate the skills of the people on site as opposed to transporting the skills of a specialist from far away, where maybe you get an interventional cardiologist who can remove a clot and just leveling the playing field a bit.
If, if you go to the ultimate end game, you want to be able to have the skills at the place of care, not
Yeah.
reliant on somebody else telesurgerying in. Because again, as Joe says, it just might be that expert's just not available at that critical minute. For these unscheduled cases where it's an emergency, you might not have the person there. And I'm sure we're going to try and work out to have the whole on-call register and all that kind of stuff. But ultimately, if you can have the ability for the local teams to be augmented so that their skills become as good as the world's best through augmentation, that probably, for many of the things that Joe says, also for legal reasons, timing reasons, network reasons, all of those good things, ultimately what you ideally want is that out in Wyoming, through augmentation, they are as good as the
Mm-hmm.
best center anywhere in the US.
Mm-hmm. All right, great point. We've taken 10 minutes on the first point, so we're never going to get through this under under an hour if I don't move things along. Joe, you mentioned that you had moderated endovascular robotics panel. Let's talk a bit about what you saw on that panel, and more broadly, folks can tell me what you saw at the meeting. So,
Yeah.
Joe, how'd the panel go?
Well, first of all, great for Vip Patel to start expanding out the sort of form factor there, because after a while, if all you're doing is soft tissue robots, it might be Groundhog Day every year there when you start to look at form factors, and certainly robotic assisted surgery is critical in nature. But the endovascular side I thought was really interesting. So we had who we had there? We had Nanoflex, we had Microbot, we had Sentante, we had David Fichel's company, Stereotaxis. So a really nice panel across the board. Robocath too, don't let me forget that. But what was very clear was on that panel there was a gap where we had two interventionalists there, Ryan Matter and Adnan Siddiqui, but we didn't have the strategics there. And so my advice to VIP was love the fact that you had the platforms there. However, without the strategics there who talk about how do we get the imaging in there? Because without imaging, you don't have endovascular robots.
Mm-hmm.
And then, is there enough interaction there between a group of surgeons, a group or interventionalists, a group of strategics, and the people building the endovascular robots? There needs to be more exchange there, because I'm afraid that a lot of these CEOs that I saw on the panel, great thinkers and great CEOs, but there's a lot of unidimensional thinking going on in those companies. And the big strategics need to be there to make this category happen.
Steve Bell, rebuttal. No. Do you have any any insights from Joe's panel or things you heard in the hallway?
Yeah, look, so I think, again, 30,000 feet, the fact that we're even having this discussion now is very encouraging. I think in 2019, we wouldn't be having this discussion. We wouldn't be talking about
Right.
these robots. I think it's a theme that I saw there, which is this wasn't a surgical Da Vinci-like robotic meeting with 3 or 4 clones of Da Vinci. This was about a number of different robots in different categories, different approaches to different things, different segments, including we had some dental in there as well. And this is, I think, is, a real testament to the meeting and to VIP and to the organizers, that it's now no longer this just pure surgery play.
Mm-hmm.
So I'm just really encouraged that we're even having the discussions. That's number one. Coming to what Joe says, I agree 100%. You can't have these isolated discussions without looking at the whole ecosystem, especially when imaging plays such a critical part in some of the delivery of these robots. So again, I'm in favor as well, where we need to have all stakeholders from the industry, especially, but also, you've got to have the right radiologists, you've got to have the right interventionalists in the room at these panels, just to make sure that we're getting a holistic 360 view of this, because it is complex, and it's going to be very complex to make this all work together in a rational way. So yeah, I agree with Joe that you've got to have everyone at the table.
Yeah, and Tom, just wrapping this subject up a bit, even though they were off in a corner, but they still had big crowds. You had Histosonics there,
Mm-hmm.
and you had Insightec there. So that is part of the next growth of surgery, is incisionless surgery. I had the opportunity to sit with Fred. What's great is it's like Cher, or everybody knows Fred, right? Fred Mole. And Fred and I were talking.
Fred'll do.
And Fred'll do. And I said to Fred, I said, Fred, you kind of are the godfather of this, right? How do you feel about it and where it started? He goes, I don't think about the robot anymore. He said, surgery was as small as an incision I can make with as little stress in the body as I can make and as great access as possible. And then I challenged him. I said, well, what about if we don't have to make an incision? What if we can take energy delivery like a Histosonics and not just manipulate tissue or remove tissue, but also prep tissue for an additional therapeutic use on it, which Histosonics does, and there'll be some white papers coming out on that. So, and then in the booth next to that was Proximie, right? So
Mm-hmm.
what we have to be careful in robotics, Steve, is the fatal unconnectedness of the OR. Because if we look at the OR as a series of siloed solutions, and again, it's a fatal unconnectedness of looking at an entire system, and that's what was great about having it in Europe. Was in the US, that show has surgeons, healthcare administrators, payers, all at the attention at the booths. At ERCAD, you didn't get that cohort, so people were talking to themselves, and more cross communication was happening company to company because you had the opportunity time. So I just see this show, and even challenging VIP, it might not stand up anymore as Society of Robotic Surgery. It might have to be something else, and that's a good thing.
Mm-hmm. All right. Let's talk about the 800-pound gorilla in the industry, Intuitive. Steve, you had a great part of your blog post, and the blog is part of your How to Start Up in MedTech platform. People should certainly subscribe. You described it as intuitive, sort of flexing. Dave Rosa, CEO Dave Rosa, was there for the entire time. You commented that the other leaders from larger strategics weren't present, and I think you said the interviews were recorded. They weren't even live interviews. Uh, how did Intuitive handle the week? They opened things up again. I had an article with them talking with Brian Miller about telesurgery and his imploring, like, look, we need to find a clinical use for this. We can't just do it because it's neat. It needs to be something surgeons demand. How did you see Intuitive walking through the meeting, and what does the state of where we are with this industry mean for Intuitive? They're still leading, obviously, but any changes in the horse race?
No, look, they do a great job of being a leader in the industry, and
Hmm.
they officially launched their Da Vinci 5 for Europe because they got CE mark.
Yep.
That is a big event. I got a feeling that there's a lot of hospitals around Europe been waiting for that. There's a little bit of pent up demand for that, so that's interesting. They launched a curved sealer extend, which is more advanced energy. They had a very reserved way that they talked about the telesurgery. They want to do it. They don't want to be first. They want to be right. And I found that quite interesting. And they have been involved in telehealth for a long time. Their systems have been able to do that for a long time. But they demonstrated that with some, extra things. They were able to do force feedback over the telesurgery. They were able to do some very nice demonstrations of handoffs and handbacks
Mm-hmm.
of the instruments. So they are going to do it right. And my comment about Dave Rosa is that you have the CEO of the company come and spend significant time at the meeting. That is a signal to the industry, it's a signal to the society, and it's a signal to the market. And this isn't a side project for them. This isn't something that they have to do as well as running 15 other things in a company. This is their focus. And it just speaks volumes to me when they turn up there, especially an important thing like an investors day, when you have all the analysts in the room and you have a lot of important investors in the room, people who put money in their, from their funds into their company.
Mm-hmm.
I just think it's the right thing to do. And it just speaks volumes to me on leadership that comes from them.
Joe, how did you interpret Intuitive's stance on telesurgery? They are being cautious. They seem to be pulling back in the reins. Is this maturity talking? Is this experience talking? Is it them trying to just put some cold water on some competitors that are, that seem to be making a lot of news in this space? How do you read that?
What is that? There's a saying, I want to know where and when I'm going to die, so I make sure I don't go there. Right? So with Intuitive, I want to know where and when you're going to beat me, and I'm not going to go there.
Yeah.
Right? So that's the first thing that's sit on the entry point of every soft tissue surgical robotic is, where and when will Intuitive beat me? Because I don't need to go to that market. Yet some still people are pig-headed trying to go into the OR with their robot.
Mm-hmm.
And so Intuitive doesn't have to solve today the telesurgery problem because they're everywhere anyway.
Mm-hmm.
And I think it actually, you shouldn't be highlighting a capability that potentially could be a threat. Not a big threat, in my opinion. And I think Dave and team will demonstrate that they can do that. If any robotic company can do it, they can do it. And so I think they're doing that. And I think Dave's a different leader than Gary. Dave is a man of the people. Gary, while genius, he was never, the outward-facing leadership CEO. So they're just different people there. And I think Dave is just being a good ambassador in general. I think it's a miss all the other CEOs weren't there. But again, I'm not a huge, I would not be putting in my top 5 initiative telesurgery where I spend my money.
Mm-hmm.
If I was a robotic company, you got other problems to solve there.
Interesting. Let's move into another space that I know you track closely, the ASC market, and it's an opportunity. You've presented it, and Steve has as well, as an opportunity for other surgical robotics companies. Any insights gleaned from SRS regarding what kind of products we may see in that space, how that area may be served?
Yeah, I'm still amazed and frightened for that category, that not enough people really see that category being the highest growth percentage in surgery or cath labs or procedures in general. Look, the payers are when you have aligned incentives, and there aren't that many in healthcare, which is why we have issues. But when you have aligned incentives of lower acuity, lower cost, better outcomes, better service, being pushed to those, at least in the United States, let's just talk about the US, you ought to be there. Again, going back to tell me where I'm going to die and I'll make sure I'm never going to go there. Intuitive's not playing there yet. And so I think you saw Distal Motion double down on it. You saw Moon Surgical double down on it. I believe that people are starting to get it, but even in the endovascular panel that I did, they were ill-equipped to answer the ASC model, and they were still even fumbling with the economic model of they're still thinking CapEx acquisition when ASC is all about OpEx on the balance sheet and surgery as a service mentality. And even all those endovascular CEOs were sort of had the 1,000-yard stare when I brought up ASCs. So that's a little concerning to me, that they are pursuing the technical challenges, but they really aren't looking at the business opportunities.
No, that is concerning. Steve, how do you view it? You were nodding your head through that. I don't know what you can speak globally, of course. I'm not sure of the ASC situation in Europe, but speaking about the US, and give us any insights on what's going on
No,
in your part of the world.
yeah, no, there is. So interestingly, Smith and Nephew just set up an
Yep.
ASC in the
Right.
UK. So that kind of model is coming to Europe, and there's equivalent models across Europe with clinics, private clinics. There's even some surgeon-run clinics around Europe as well. So I think it's equivalent, and Joe nails it, which is the trend is the move to that site of care where possible. Right procedure in the right place. What I did see at the meeting was there are some form factors of robots coming out that are quite different. So that, if you look across the last couple of weeks, you've had things like Think Surgical, which has come out with a handheld orthopedic total knee arthroplasty robot, handheld. There were, I can never say it,
Mandira. Yeah, I was just trying to figure it out myself. Yeah, I think it's Mandira.
Mandira, and they've got they've got a handheld percutaneous needle robot. You've got handheld central venous catheter. You've got form factors that will fit and play better into that location, size of location, footprint of location, and workflow of location. You're not going to change so much the education of the staff. You just have to give them sort of delta training on how to use the system. So I think some people are thinking about it a little bit, but by far, Joe's right. The majority of people are not. They're deep in the tech solution, and they're not thinking of the commercial solution that needs to play into. And I've said this for a lot of companies. They've got to get the commercial side from a financial side right, because the financials in an ASC and a clinic are so different. It's totally different than anything you'll see in the main healthcare hospitals. But it's also from the commercial of how do you deploy and how do you get your marketing and your sales teams into that space and working in that space and talking to the right people that make the decisions in that space. And I think a lot of companies are very ill-equipped for that.
I would agree with Steve on that. And Steve brings up 2 points that are aligned here through association. The leadership set this culture that they're so focused on the technical solutions. Yet you've got to back out on this and go to where you're going to die on the cross. 2 items. How do you make the commercial acquisition of this work? Right? And how do you, so that's economics. And then stepping back again on economics is, how do you set cost targets early in the product development side of things? And I will tell you that as I go around and talk to people in the booths, and I start asking them about the technologies and then the R&D, and then tell me about your cost targeting on the product development side, I almost get a cold stare. And so if you can't get those cost targets down, and you can't rationalize that OpEx cost to the site of care, you might have one of the best robots in the world, but you're never going to be able to make it economically work, whether you're looking for acquisition or you're a large strategic, and year after year, as you stand that up, you're going to be bleeding. And one of my favorite terms I heard was when Auris was bought by J&J, they finally realized that Auris was built to be sold, not to be scaled, their Monarch system. And we ought to study that really closely. The venture money ought to study that really closely, because the VCs, I mean, the strategics are. So that's a call out, especially to the endovascular category, more than anybody else, because soft tissue is already baked in. That's where they are.
I think Joe's right there again. And there's two ways that you make that work. And one of it is, you just make the price, let's say a catheter. So you make it single use, and you get the price as low down as you can for the cost of making that single use. Or you go for another strategy, which is a little bit like what Intuitive did with their instruments, which is you make them multi-use, but you make them easy to clean, and you make it where your cost per case target is really, really low. And it doesn't really matter which one you end up with. But the one thing I feel is they have to fit into current payments. The ability to change payment structure is so difficult and so impossible. As teams, I would be sitting there saying, okay, they can pay $400, and we need to make X% margin on this. And therefore, either as a single use or a multi-use or a reusable, whatever it is, the cost per case to us needs to be this, or we don't make the money. And I don't think there's enough thinking of that going on early on in these, especially the robotic systems.
So I know we're running up against our time, but just finally, it's a big question. But AI is in sort of the evolution of surgical robotics into digital surgery. It's a much bigger platform. Is AI adding to that tech noise, just making it more of a technical project that's going to even make it more muddled and more difficult for adoption, or is it the solution that's going to actually make surgical robotics easier to find a home under those reimbursement codes and in traditional healthcare? Is AI a problem or a solution, Steve?
So I think that the dream of where the big AI goes in the future, when we're seeing all these, autonomous surgery and stuff, and the John Hopkins stuff we show, great and fantasy, and I think it's the right trajectory to go for. I actually was more impressed by some of the early small wins. I talked with a number of surgeons, and they said, oh, we're already using large language models to do things like note taking, or it's a lot of the small administrative stuff that has just eaten into clinical care and just become the burden of so many care teams. I think the AI there is actually already starting to chip away at that and make that a little bit better. Still to go mass adoption, but I think that's where you're going to see real benefits straight away. The thing about the robots, and we did the Shark Tank, and there was lots of AI at the Shark Tank and stuff like this. My underlying question to all the companies all the time is, who's going to pay for it? What if this will just be a table stake as part of you deliver a robot and it just has to have it? What if it will be an add-on that someone's willing to pay for? What will be a freemium? What will be a premium? And I don't think we've really got that worked out yet as an industry.
Last word to you, Joe.
I agree with Steve. I think the early adoption, which will really help the clinician surgeon a lot, is going to be in the non-FDA regulated efficiency of workflow. So that's one, and people should be excited about that, and not rush it. Then you can step into imaging. I think we're going to get early adoption, high adoption on the imaging side of things. And if you slide into robotics, I think you'll get, like the ISU has, that Ascensus has, is use that AI for guidance, tissue characterization, go or no go zones, et cetera. So those will be super helpful as well. And then finally on board, in like a Moon has, where they've cleverly put their AI system and their AI agent in their robot looking out into the room, where it's almost like a Trojan horse, because
Hmm.
it's going to be offering guidance, insight, agentic AI on advisement on setups and things like that, gathering all the information where others are trying to be in the periphery, putting cameras, trying to negotiate with IT, negotiate on the cyber, coming in. It's a real headache. So I think those are the areas first. But I think we've got years ahead of us from an FDA perspective, just stepping outside of workflow, imaging, and maybe advisement and setups of the system itself.
Fantastic. All right. So I understand SRS 2026 will be in Miami next year. Is that correct?
Yes.
All right. So I hope we can do this in person then. You folks, this feels like I only came to know SRS a few years ago. I went to my first one last year. Again, I regretted missing out on this one. Hearing from you, it sounds like we're taking a generational, an evolutionary step for SRS. This is going to become one of the must-attend meetings. Do you both agree?
Steve?
Yeah, yeah. I think if I can only go to one meeting a year, I would go to this one.
Mm-hmm.
Yeah, and what'll be funny is you're either going to be satisfied with the status quo or frightened by the difficulties of change in the robotics world. And that the bold will be rewarded on the people who move forward in that category.
Fantastic. All right. Well, thank you both for easing my my regret of not being there this year, and look forward to having additional or future conversations with you both. Thanks so much.
Thanks, Tom. Thanks, Steve.
Cheers, guys.